Okay, thank you. So we're going to speak this afternoon about a survey that Rick and I have led for iPANEL to have a foundation for iPANEL's work in relation to understanding and integration of the palliative approach in 3 settings: hospital, residential, and home care nursing, a provincial-wide survey. And of course, iPANEL is funded through Michael Smith Foundation Health Research Grant, BCNRI initiative. So we'll be speaking about the provincial survey. And iPANEL, the broader iPANEL initiative led by the two PIs are Dr. Kelly Stadjuhar at University of Victoria and Carolyn Taylor, who's the Director for End-of-Life Care in Fraser Health, as well as a broad base of academic and practice co-investigators. And the question that our team is interested in is looking at really digging into this concept of how can a palliative approach better meet the needs of people with chronic life-limiting conditions and their families. And we're looking at what context, in which context can the palliative approach be better meeting the needs of people with the chronic life-limiting conditions. And of course, we're talking broadly about chronic life-limiting conditions, including people with dementia, chronic organ failure, longer range cancers, and we're hoping to look at how we can guide the development of innovations in healthcare delivery systems to support nursing practice. So that's our broad question. And so the notion, just briefly about a palliative approach, we're really talking about taking the principles of palliative care and those holistic, broad-based principles and philosophy of palliative care and applying them to people with life-limiting chronic conditions. So not waiting until there's death on the horizon or we're clear that there's a clear prognostic expectation that someone will die in weeks or a few months. We're really talking about taking the palliative care principles and applying those more broadly and not being constricted too closely with prognosis. So anybody that has an illness that is going to progress and they will die from, and many people with congestive heart failure, emphysema, dementias, renal failures. So we're talking about applying that holistic approach around people's needs, wishes, comfort, psychosocial, spiritual, cultural care, information that they need, and recognizing that their disease will cause their death and the family will need care after death. There's many specialized palliative care services that have been developed over the last 25 years that are important. It's recognized that when we're talking about many people with chronic disease, they don't require care from specialized care services, but they do require palliative care. They do require that approach to care that's focusing on their quality of life and preventing and relieving suffering, early identifying their needs, and treating them holistically. And oftentimes in our system right now, there's many people that are not being identified as benefiting from a palliative approach. So that, when our team came together, then to have, of course, one of your first questions is, where are we now? What is our foundation? And so to answer that question, the iPANEL supported doing a provincial survey of nurses, RNs, LPNs, and healthcare workers. And so that's going to be, we're going to report the findings of that. So we approached it in a mixed method design. So to get at this baseline information that will inform us about our future questions around integrating a palliative approach, we looked at the 3 settings that are the iPANEL's context of interest, which are our acute medical units, home care, and residential care. And the survey was specific to nursing, looking at RNs, LPNs, and healthcare workers in those settings. And the objectives of the survey reflect the interest and the focus of iPANEL. So these are our questions: how and to what extent is a palliative approach applied? So in these 3 different settings, we wanted to look at what knowledge, skills, and confidence do nurses already have in palliative approach to care, and we'll talk about how we approach that question. And how do we best assess their self-perceived confidence for a palliative approach? And we're also looking at, when we gather this information, expert opinion about improving the integration of a palliative approach, which is further work that we will be doing beyond the survey. So the design was this mixed methods research design in the 3 sectors, and so we did a survey. Rick's going to talk more about that. So that was the quantitative approach. There was some opportunities for people to comment within the survey, and then beyond that, we actually had interviews.
So I'll continue giving you a bit of background about how the survey was conducted and how the analyses were done, and then we'll go into the results quite quickly. So we won't provide too much background because I think it will become clearer as we go along. But so the first thing we had to do is get a representative sample of the province of BC, which is not so easy because if you just draw a random sample in BC, you get the greater Vancouver area and you miss the rest of the province. So we wanted to actually ensure that a wide diversity of voices were represented across all health authorities and all geographical location in BC. And to achieve that, we constructed a sampling frame, and from which we drew a random sample of medical units, residential care facilities, and home care agencies throughout the province. This was clustered within each health authority, each of the 5 health authorities, and then the sample was stratified by size and by type of facility. So that was the stage 1 of the sampling, getting a diverse set of a diverse representation of different settings throughout the province. So then, and then after that, we asked all the RNs, healthcare workers, and LPNs within each setting to participate. So briefly, it looked like this. We have 5 health authorities, regional health authorities in the province. Of course, we also have the provincial health authority. But this was focused on the 5 regional health authorities. We constructed a sampling frame. We worked with the Ministry of Health and the directors within each health authority and their decision support systems to create a sampling frame of all the medical units, all the home care agencies, and all the residential care facilities within each health authority. And then we randomly sampled within each health authority from that sampling frame and stratified that by size and by type of facility. And then all the RNs and LPNs and healthcare workers within each sample setting were invited to participate. So our sample actually looks like this. The sampling was done in 2 phases, phase 1 and phase 2. That's really not so, it doesn't matter too much. But as you can see, we got diversity rates throughout the province here. Ebola was so kind as to go all the way to Queen Charlotte Island and get the surveys there. So we got a good representation of northern health, interior health, Vancouver coastal, a lot, of course, mostly lumped over here. We got a good chunk of the island, all the way across the island, and then Fraser Health Authority over here. In total, we have 114 settings, which is not showing here right now. There we go. So 114 settings throughout the province. Then, once the settings were identified, we asked all the nurses to complete a questionnaire, and I won't tell you all the details about how the questionnaire was administered, other than that nurses had the opportunity to complete the questionnaire online or on paper. Everyone got a paper copy or by phone. There weren't very many that did the phone method. And then, of course, they got appropriate reminders, several reminders, as well as a thank you card, and that was done both electronically and in paper format. So the questionnaire included a series of questions about confidence in applying a palliative approach. And so for this we use an instrument that is on the next slide here, the Self-Perceived Palliative Care Nursing Competency Scale that was developed by Jean-François de Bien, who's at Laval University, as part of his dissertation work. He's a assistant professor there right now. And so it consists of these 10 kind of dimensions of care that are relevant to a palliative care or a palliative approach. But it's not meant to be comprehensive. So there are other aspects of care that are not mentioned here. For instance, disease management is, of course, a very relevant area. That is not the focus here. What I was focusing on here is a series of patient care needs, including physical needs, to doing with symptom assessments and other symptoms, psychological needs, social needs, spiritual needs, and functional status needs. And then also some other areas, aspects of care related to ethical, legal issues, interprofessional collaboration, personal professional issues related to nursing care, and then the last hours of life. And so there were 5 questions for each of these 10 dimensions. And so the questionnaire consisted of 50 questions in total that were then rated on a competence or a scale of how capable people feel in addressing these areas of need. So that was part 1 of the survey. The next part then focused on the integration of a palliative approach. So it asked questions about, how many people on your unit, or what is the proportion of people on your unit that have a life-limiting illness, and how many of them would benefit from a palliative approach, and then how often do you actually apply a palliative approach, and a series of questions along those lines. Then there was a section on the survey on knowledge and education that got on how people rated, the participants rated how adequate their knowledge and education is in relation to each of these 10 dimensions. And there we also included disease management and a few other areas. And they also provided information about what the source was of their knowledge. Was it basic education, ongoing education, context in practice like experiential knowledge, etc. Then the next fourth section on the survey focused on work environment. We used a modified version of the Nursing Work Index, which was the same version that was used in the 2005 National Survey of the Work and Health and Nurses, so it allowed for some comparability. Then, of course, we had some demographic questions as well. So that's what the survey looks like. And then so that's kind of the quantitative component of it. Then, as part of the survey, everybody was invited to say whether they would be commendable to having a qualitative interview, either by phone or as a focus group or in person. And so that data was then collected. We're going to say a bit more about that pretty soon. And then we used standard qualitative analysis methods to identify patterns and themes within that data as well, and to get a better understanding, really, of the quantitative survey findings. So the results were really meant to go hand in hand. And you could attach a number to something, but then it's also helpful to have a quote to kind of figure out what that number actually means. In the next couple of slides, about 50 or so, we're going to present you the results of the survey. And so we'll just say a few things about the sample description, and then we're going to go through these questions, which pretty much map onto the objectives that we previously mentioned. So I'm not going to repeat them here. So just briefly, we had our total sample consisted of 1,468 RNs, LPNs, or care aides throughout the province. And this mosaic plot provides a bit of a description as to how they divided across the 2 categories. Remember, we have 3 different care provider groups, RNs, so 42% of the sample is RNs, 20% of the sample is LPNs, and 38% of the sample is care aides. And then we had 3 different care settings as well. One is home care, it's 26% of the sample, residential care, 46% of the sample, and hospital medical units, 28% of the sample. And these areas here show you how it divides. So in hospital, we're not surprised to see that there were more RNs than LPNs. And in residential, we're not surprised to see that the majority is care aides and also some RNs and LPNs. And in home care, that there are hardly any LPNs in home care. There were actually just a few, but they were not included in our analysis because the sample was too small to say anything meaningful about it. There were 8 in total. So that's what the sample looks like. And then, of course, we did have all kinds of descriptive analyses of you know, who are these the nurses that actually responded to the survey. And one of the interesting ones to look at is age, and we see here a not so surprising pattern. So the average or median age of RNs, for instance, in hospital units is quite a bit lower than the average or median age of RNs or LPNs and care aides and RNs in the residential and home care setting, which is not surprising. To some extent, that's how our practice environment is structured. Many new graduates go initially to a medical setting, and so that's going to bring our average age down in hospital medical units, and home care settings are deemed to, you know, a common hiring practice is for to require a couple of years of experience before going into home care. So that's how the ages distribute. I won't give a gender distribution because there weren't many males for some reason. I don't know why, but there weren't many males in our sample. So were you going to jump in here?
Sure. Yeah. So it was interesting, if you think about those almost 1,500 nurses, there were about 300 of those who indicated they would like to participate in an interview or a focus group. So people were very interested and engaged. Of those, we interviewed a small subset of those, so 30 nurses, included 2 focus groups to make up that sample, and all health authorities were represented. The majority were RNs and LPNs, but there were some care aides that completed the focus group or completed the interviews, and the majority of those who did participate actually worked in home health and residential. We don't have this on the slide, but we also had, there's a number of qualitative comments throughout the survey, which is another area of rich data for comments that actually help to explain what we're seeing in the quantitative results.
So our first thing that we looked at how confident do care providers feel in applying a palliative approach. So these are these 50 questions, and it's hard to represent this kind of data. How do I get rid of this thing? Keeps blocking our slide. So basically, each of these bars, I'm going to explain this bar graph because it's going to come back several times in our presentation. Each of these bars represents a question. So there's 50 bars corresponding to 50 of the questions. And the dotted line here is indicative of the 0% line. So what is to the right of the line is a percentage of people that responded 3, 4, or 5 on the capability scale. And what is to the left of the line is a percentage of people who responded 2, 1, or 0, not at all capable. So the scale went from 0, not at all capable, to 5, highly capable. So, of course, what we're mostly concerned about is what is to the left of the line, which is colored in red. And so here is all these, the dimensions, and this percentage here represents the cutoff. So this percentage is the size of the bar to the left, but within each of the care provider groups. And so, for instance, you can see here in terms of pain management. RNs, 5.5% of RNs felt that they were less than capable. They scored less than 3 on the capability scale, whereas 9.9% of care aides felt that they were less than capable in that area. It is important to note here that we have kind of colored the care aid bar because they had slightly different questions. The questions address the same topic, but they were modified to correspond with their scope of practice. So right away, you could see here challenges in the area of social needs, spiritual needs, and ethical legal issues, and some other areas as well. But of course, the overarching message is that nurses overall feel relatively capable, but there are some areas to continue working on. So, for instance, I'll highlight a few where nurses felt very confident. Here is providing mouth care for people with chronic life-limiting illness. Everybody feels really quite capable in this area. It's unfortunate that we don't all do it, but nonetheless, we feel very capable. Then, it's similar into functional status. We won't be surprised that many feel very capable in the area of assisting people in their functional independence as long as possible. But when there are some other considerations, the pattern looks slightly different. So, for instance, for people with life-limiting illness, of course, the family caregivers are very important as well. And that's where we see that care aides in the home and nurses in the hospital, as well as care aides in residential care, are saying, well, we don't always feel so capable in that area. And so we might benefit from a bit more confidence building or helping us retain more competence in that area. Similar for social needs. So now I'm going to highlight a few where people feel less confident. So in the area of social needs, promoting communication with patients and the family caregivers when a conflict occurs, which is a relatively frequently occurring situation. And so, care aides at home are saying that, we actually don't feel so competent in that area. That's almost 25% of the care aides. And similar care aides in the residential care are saying so. But there's also some nurses and LPNs that are saying, we need to actually pay more attention to that in terms of our capabilities in addressing those needs. Not surprisingly, perhaps, is the spiritual needs, where, of course, many people feel not very capable at all. Almost half of the sample in the hospital and almost half of the care aides in home care do not feel as capable in that area. It is interesting that in residential care, people are feeling relatively more capable. Ethical legal issues, probably not surprising to us either. We see a similar kind of pattern. So,
yeah, so just to kind of summarize, what are we learning from this is that the areas that nurses across all three are feeling less confident are spiritual, social, ethical, legal, and interventions to support family caregivers, but also in relation to some areas where they felt confident, like pain management, they were less confident in non-pharmacological interventions, and they were less confident to relieve complex symptoms such as fatigue. So that, and overall, nurses in hospital settings relative to those in home care or residential felt relatively less confident applying a palliative approach. So as far as an area that requires more focus. The qualitative interview themes mirrored some of these findings. Here's a quote from a home health nurse and saying, ethical is the most difficult. That's one I've struggled with in my nursing. That's when we try and conference with coworkers. There's someone, if we run into a legal or ethical thing we're not sure about, she'll advise us. So that came through in the qualitative as well. We've got another couple of quotes in relation to this notion about families and supporting families, about how important it is. So a home health nurse saying they depend on you, they lean on you, they need your support. The family is the most difficult. Not all the family agree on what the patient wants. And of course, in the context of home, family is a very important context. As far as their approach, the notion about grounded in what is important to the person and families, there was a theme in the qualitative interviews about palliative approach requiring very respectful and accommodating care. And so this is a quote for an LPN, which really reflects open-mindedness and acceptance.
So that has to do with confidence in a palliative approach. And the next piece is that we looked at is nurses' knowledge. How do nurses, now remember that this is all nurses' self-perceptions, right? Of their capability, of their knowledge, of their practice. That's what the survey focused on. So do nurses view their knowledge as adequate? And if not, then that's something to pay attention to. Now, overall, we found that the knowledge actually pretty much, perhaps not surprisingly, was highly correlated with the competence ratings, but not entirely. So we see here the same 10 dimensions that I mentioned, but the disease management is added here. And it's the same idea. The scale is slightly different. It's a 5-point scale that goes from inadequate to more than adequate. And what is highlighted here is the percentage of RNs, LPNs, and care aides that say that they are less than adequate, so a 0 or 1 on the scale. So just for the sake of comparison, we could have also taken a 0, 1, or 2 on the scale. But that is what we're showing here. And so we see some very interesting findings here that, for instance, in disease management, RNs and LPNs, of course, are feeling relatively more, their knowledge is relatively more adequate. But in care aides, of course, it's not really within their scope of practice, but remember that the question is asked with respect to their scope of practice. So care aides are saying here that almost a quarter of them are saying, oh, we need some help here. We need more knowledge. That's what they're telling us. And remember that to say inadequate or less, this is quite a threatening thing to say, like these self-reports. So they tend to be underrated, and so that's another important thing to keep in mind. Some other things to point out, we already identified the social issues before, and the spiritual issues. We're not surprised to see that here. And the ethical, legal issues, we're not surprised to see that here either. So that corresponds pretty much with the competence rating. I'm not going to go into much detail here, other than we did the same type of comparisons. So this one looks at disease management, and here you could really see the care aides standing out in that area. For loss and grief, it's pretty much homogeneous across the board. However, RNs in home care feel relatively more competent, feel their knowledge to be relatively more adequate there, which is an interesting standout there. Oops. Oh, that's it.
So this is another way of summarizing the areas that providers viewed their knowledge as less than adequate. So we've just got the bars to compare the 3 different providers, the RNs in black, the LPNs in the brighter green, and care aides in the darker green. And so these areas will be areas for us in relation to focusing on recognizing that knowledge needs to be better supported. And even though we've compared the care aides to the RNs and LPNs, recognizing that their scope is different. So as we looked at sources of knowledge, asking in the interview, where did people go to for information? And what we learned was that practice experience was the greatest source of knowledge for the dimensions of a palliative approach. So rather than rating their basic or continuing education as a strong source of knowledge, practice experience was the greatest source. And interestingly, face-to-face learning was the most preferred method. We asked a variety of learning methods, And colleagues we asked a question, where would you go if you did not know something, to a variety of areas, and colleagues were the source they identified most going to. So it really shows this relational aspect of people's learning. And in the qualitative interviews, they actually talked about different kinds of knowledge that they needed, reflected by these 4 themes of practical, expert, ethical, and knowledge of themselves, which is very important to a palliative approach. Just a couple of quotes that supported this. I'm more of a hands-on learner. It would be spending some time in a care setting, right, doing it, brainstorming in terms of possibilities for care of people or ideas. An LPN, what I mean to say is that you'll have some care staff or some nursing staff that are experienced in palliative care that can help you. So the qualitative themes very much reflected what the quantitative survey findings were showing us. And again, this area of self-knowledge, a carried saying, all of us have our own dilemmas and issues with death. And when dealing with other people's deaths, it really helps to put our own in perspective. So there was many very insightful comments actually from the care aides throughout.
Mm-hmm. And notes of appreciation from the care aides for being included in the survey.
Yeah.
They're often not included in this type of survey.
And when you think 38% of the sample was care aides was a very good response.
Yeah. So, having looked at confidence and then at knowledge, the remaining questions then are, to what extent do nurses identify patients with a life-limiting illness, which is obviously a condition for applying a palliative approach. If you don't identify people as needing a palliative approach, you're not going to provide it. And then secondly, do you actually believe that a palliative approach will be helpful to these patients? And then finally, do you then apply a palliative approach? So there were a series of questions about this, and this graph is a little bit complicated. But basically the question was, in your practice setting, how many patients out of 10 have a life-limiting condition? So this gets at the proportion of patients in your practice setting. And so the result is here on the x-axis here is the number out of 10, and then the frequency is on the left axis here. And then the blue bar is residential, then home care, hospital, and home care. And so we could see right away is that, for instance, in residential care, about 40%, almost 40%, of the respondents say that all their patients have a life-limiting condition, which is in some sense not surprising that that would be the highest. In another sense, it is surprising considering that almost all patients in residential care have a life-limiting condition. So we would have expected this bar to be way up here. And so that's an interesting finding right there. But nonetheless, we look at these bar graphs here superimposed on this. In residential care, nurses and care providers are more likely to identify people with life-limiting chronic illness. Another interesting finding is that in hospital care, which is indicated here with this color, the center bars, we find that quite a few, like only half of the nurses, indicate half of their patients of having a life-limiting chronic condition, so or less. And so this is also surprising because all the medical units were carefully chosen. We had certain selection criteria to identify units that predominantly had patients with chronic life-limiting illness. So it's way underrated, which suggests an identification problem. In home care, it's not so surprising because we weren't able to sample nurses that did exclusively care for it. Like they did the whole scope of home care nursing, and so it's not surprising that there's more of a mix there. So that's identification. We see a similar pattern for the question in your practice setting, how many out of 10 patients with a life-limiting chronic conditions would benefit from a palliative approach? So after you've identified people with a palliative approach, how many would then benefit from it? And we see a somewhat similar pattern. So these people here are saying about 40% in home and residential are saying that, yeah, people with life-limiting chronic illness would benefit from a palliative approach in my setting. Only 20% of the hospital nurses are saying that all their patients would. And so you see the same distribution across for the number out of 10 patients.
Explain the mean.
The mean?
Yeah, just so the
median.
Yeah, the median at the top.
Yeah,
just
so this
people
here is the median rate here for hospitals. So it's saying that that 50% of nurses in the hospital are saying that less than 5 out of 10 patients have a chronic life-limiting illness or would benefit from a palliative approach. And in home and residential care, they're saying about 8 out of 10.
And I think what we'll do is we'll press through and then have questions at the end so the folks on the webinar can also participate. Yeah.
So the last question then, not the last question of the survey, it had about 200 questions, but that we're addressing here is then how often do you apply a palliative approach then for people with chronic life-limiting illness? You will not be surprised to see a strong correlation with this previous question. If you believe that it will work, you're likely to apply it. But again, the hospital does really stand out here. We can see that on average, people in the hospital settings are not nearly applying a palliative approach as much as people in residential or home care settings. And note that this is already focused on patients with life-limiting conditions. So it's already controlling for that. So our final set of questions then was, what about this diversity? So we see that some nurses are providing a palliative approach and others are not. And why is this? And so we did a regression analysis to, I think I'll just move on to regression.
Yeah.
Regression analysis to unpack that for us. For those who are so inclined, it was a mixed effects binomial logistic regression analysis that is controlled for clustering within units and also controlled for the sampling design, the unequal probability of selection. The variables into the model here, and this is not the final model, include those dimensions of a palliative approach, the work environment, demographics, care setting, and the type of care provider. And so just very briefly, these are preliminary results, so I'll just touch on it here. But just to orient yourselves, we had a series of questions here. These are the confidence in applying a palliative approach dimensions. So this is a summary of the 50 questions. And the ratings here are odds ratios. So they basically give a sense of how likely you are to apply a palliative approach if you are, for instance, here better at symptom management, then you are more likely to 1.7 times more likely to apply a palliative approach. That's how you interpret this. Then we have the nursing work index one, and then we have these other questions over here. But the next graph will be more informative to you. One thing to point out here, though, is that here is where we see the difference in settings. So people in residential care relative to hospital are 1.6 times more likely to apply a palliative approach. People in home care are 1.7 times more likely than people in hospital to apply a palliative approach. But the interesting thing is, once you take into account confidence, and mainly confidence, these differences between care settings drop out altogether. So it's actually not so much about the care setting, it's about self-perceived confidence and knowledge about a palliative approach. So the width of these bars are an index of relative importance. So we're trying to explain how likely it is that nurses apply a palliative approach. And the width of the graph is called a Pratt index, says how relative to all the other variables in the model, how important is it. And so we could see very clearly here that one of the main predictors is that people ought to believe that a palliative approach is beneficial. If they don't believe it's beneficial, they're very unlikely to apply a palliative approach. But even beyond that, we see that nurses who are more confident in symptom management, end-of-life issues, interdisciplinary collaboration, last hours of life, and spirituality, those areas, if they are more confident in those areas, they're more likely to apply a palliative approach. possibly one of the most startling findings for us here is this nursing work index, which ends up not being relatively very important at all. And so what this is saying, the nursing work index measures things about the work environment, basically. And what it's saying here is that, well, so it measures autonomy in practice, control, relationships, how much you're challenged in your practice setting. But what this is saying is, well, after we take these other things into account, these are not the main drivers in the model anymore. That doesn't mean that they're not important, because they might be very important for instilling confidence. So it's not to say that they're not important. It's just to say that, if we're going to focus on things, we might want to first focus our attention here and then figure out how we get here. So in a nutshell, we have learned that there's two primary predictors of application of a palliative approach. One is nurses need to identify people as having a life-limiting chronic illness, and the other is nurses need to identify people as benefiting from a palliative approach. The interesting thing that the analyses show is that this relationship between identification and application completely drops off out of the model once we consider benefits of a palliative approach. It's an example of full mediation. And so just identification is not enough.
Oops, do you want to talk about that?
Oh, yeah. So we have some remaining analyses then. So this is where we're at right now. So now what we're trying to figure out is, okay, we know identification and benefits of a palliative approach is important. So the next step are to figure out, well, what are then the factors that explain whether care providers view a palliative approach as beneficial? And what are the factors that explain whether care providers will identify a patient as having a life-limiting condition? And once we have that, and we have that information in the survey, we'll be all round to figuring out the predictors of identification, the predictors of belief. This is really about beliefs surrounding a palliative approach, and then figuring out as to, well, when we put that all together, how can we help promote this application? What are the main areas that we need to address to promote the application of a palliative approach?
And I think to know that what the survey is just helping begin to form this model, and our further research and questions will really help to identify those factors more strongly. So we only actually have a few minutes left, so I think what we're going to do is there was much more richness within the survey and within the qualitative data about just even languaging and the whole notion of when someone's palliative, and how that influenced the interdisciplinary team and how they work together, so that there was some helpful insights in relation to that. There was also insights around the context, as Rick was talking about, all of the things that actually influence and are contextual in relation to nurses. So this wasn't uncommon in the qualitative. We don't have the staff, we don't have the time to provide the care. It actually makes us feel guilty, this notion of the moral distress arising. At the same time, when you actually accounted for all of that, there were people that within that context were still able to integrate, see the benefit. And so that's kind of one of the foundational findings.